All right, welcome to the podcast, Not Your Doc Anymore, where we address the issues essential for your health and provide information to help you become your best advocate. We'll be addressing the topics today of pelvic pain, endometriosis, and painful intercourse. If you personally or somebody you know or are close to is not suffering from one of these conditions, then you're lucky. Well, speaking of lucky, I'm so grateful today that we have our expert, Howard Sharp. Just going to just say a few things about him. He's a tenured professor and vice chair for clinical activities in the Department of Obstetrics and Gynecology at the University of Utah, where he's practiced since 1995. I actually started to have interaction with Dr. Sharp since 1997, where I did my residency. He's served as president of the International Pelvic Pain Society, has held positions as chair of the FDA addressing gynecology device panel, chair of ACOG's practice bulletin and clinical document review committees. Dr. Sharp completed a pelvic and laparoscopic surgery fellowship in 1995. His areas of interest include myofascial pain, pelvic vascular pain, dyspareunia, and centralized pelvic pain management. He is an incredibly skilled and capable surgeon with special skills in laparoscopic and hysteroscopic surgery, vestibulectomy for provoked vulvodynia, myofascial trigger point injection therapy, and in the office, he is adept at listening to, educating, and counseling patients. He did medical school at Tulane University School of Medicine. Following his medical school, he went to the University of Utah School of Medicine and did an OB/GYN residency, and then did his year laparoscopic surgery in the Greater Baltimore Medical Center. And I believe that was 1 year. Is that correct, Dr. Sharp?
That's right.
Is it okay if I call you Howard while
Please, we're old friends. We're old
we
friends.
have this amazing.
I had to be interviewing you for the pelvic pain expertise. So there you go.
I don't think so, but I do have to say that everything I know about pelvic pain comes from my relationship with Dr. Sharp. Not only did I do my residency at the University of Utah, then I joined him in practice for another 5 years. And one of the things that he does, let's list it on his bio, is avoiding burnout and how to see pelvic pain patients for decades and still enjoy it. I just have to say one note on that. I remember when I first started my practice and I was getting I had learned some skills through residency, but more so in practice. I remember I was seeing 4 chronic pelvic pain patients a day. And I remember it was so difficult to chart on all those 4 patients. I remember going to you and said, this is hard. And you're like, you got to limit the number of patients you see.
Yeah.
Anyway, so I think that's an appropriate topic to address the burnout in seeing these patients. But of note, I think if I'm correct on saying this, about 30% of GYN visits are associated with pelvic pain. Is that correct?
They really are. And I will also say, in terms of burnout, the more you understand about pelvic pain and have more things to offer, over time, it really becomes a joy. So it's less a burnout. But when you don't feel comfortable in the space, like I didn't at first, it seems really overwhelming. But it's gotten easier. And and I'm sure you agree, since you've become so adept in pelvic pain. But yeah, great point. Pace yourself.
Great. Yeah. I gave you this great bio. I just have to say one personal story about Dr. Sharp or Howard. I did my residency at the University of Utah, and I remember being in a specific case. You may remember this. I don't know if you do, but I was with the guys and we were doing long laparoscopy case. And if Dr. Sharp, he's a great musician, drummer. Are you still doing the guitar or no?
A little bit. Yeah.
Anyway, but part of that is he had an amazing playlist. And not only were we tested on what was going on during the case, we were tested on the playlist. And so a song would come up and you'd say, okay, who is this? And then most of the time we had no idea. Dr. Geist was worse than I was. But after about an hour of this, and we had no idea, finally another song came up and you said, okay, who is this? And Dr. Bill Geist says, I have no idea, but all I know is they're not famous. And you said, it's the Beatles.
Yeah.
Anyway.
Remember-
Okay. So speaking of that, before we really get into the serious stuff, Howard, and we start to hear your knowledge in all the things relevant, I'm just going to play one song and I'm going to see if you know who it is and who the drummer is and maybe who the lead guitarist or the singer. I'll let you choose. All right.
Okay,
Ready?
pressure's on.
This is good.
Oh, this one I know. This is Guns N' Roses.
Okay.
This would be Axl Rose on vocals, Slash on lead guitar, Steven Adler on drums, and Duss McKagan on bass, and Izzy Stradlin on rhythm guitar. How's that? Patience?
How about the album? What album is that?
I can't remember if this is off Appetite for Destruction or Use Your Illusion. I'm not sure. You might have got me on that one.
It may be Guns Are Lies. Does that
Oh,
sound?
okay. That might be on the GNR Lies. Okay. That could be true. Yes. Sorry. I'm far from perfect on these. Too many cobwebs.
Okay, perfect. As we reached out to all of the people that are part of our Instagram, Doc Watts, and we're going to also do Doc Watts, but also Not Your Doc Anymore Instagram, and we're going to put that on TikTok. So you can find a lot of these clips there. But as I did that, there was one patient that reached out, and I'd have to agree with her. She said, Dr. Sharp has been my doctor for over 15 years, and he is the best. I trust him with my life.
Oh my gosh.
With that,
Yeah.
we got to
Too
be able
kind.
to get after the topic. Okay.
Thanks.
So our hope is today, as we address these topics, that we can really go over some of the questions associated with pelvic pain. So I'm going to start with the first question that one of our listeners had, which is, I have a teenager with crippling period pain. The OBGYN says we should stop her period. Should I, is the question. So let's maybe go through the workup for a patient like this. What are the questions that we should be asking? And we'll just go through the workup. Is that okay?
You bet. It may be different if this is a 13-year-old versus a 19-year-old, but in general, if it's really a painful period, we're always thinking about, is it primary dysmenorrhea, which is just a lot of prostaglandins being made by the uterus and cervix that are just causing a lot of pain and crampy, or is it endometriosis? And those are probably the two most common. There are a few other things that we think about, but probably not in that age category. And I would agree with that. I think stopping periods, as long as we're stopping them with something like a combined oral contraceptive pill, and not a GnRH agonist or antagonist that would completely shut the ovary down and not give them any estrogen and lose bone.
Okay.
But
Can you give me
an
example? Can you give me an example of a GnRA agonist or antagonist so that we...
So the GnRA, if we're okay to use trade names or whether we need to use...
I think we are. I don't think we're in a...
Oh, good. Okay. The GnRH agonists are things like Depo-Lupron that are shots that you get that will completely shut your ovaries down. There's a new category that are GnRH antagonists. Orlissa or elagolix are the new GnRH antagonists. So those are pills that you take. And we can talk about those. I'm not a big fan of those because with Orlissa or elagolix, you can only take it for 6 months if you're on the high dose. And if you're on the low dose, you can take it for 2 years. But if you take it for longer than that, you can lose bone. And so if you get a 19-year-old who's 19 and they say, I'm going to go on Orlissa. Okay, you take it until you're 19 and a half. And then what do you do for the rest of your life? You got 30 more years till menopause. So I never really understood the rationale behind that drug, which was FDA approved just a couple of years ago.
Interesting. And Lupron comes with so many side effects, has been my experience, that people don't love it.
Yeah, it's basically making one menopausal. So it's the hot flashes and all of the stuff that go with that. So yeah, I would go with a combined oral contraceptive pill if there was not a contraindication, or a progestin. So either would work. And certainly NSAIDs, like anti-inflammatory
Okay.
drugs, ibuprofen, things like that.
What are some of the side effects that a patient or a mother who's concerned about this should worry about for a
Well,
pill, for a combined oral contraceptive pill?
you bet. So first of all, you want to make sure there's not a contraindication. So if they've ever had a blood clot in the leg of the lungs, we don't give it to folks that smoke cigarettes because it increases the risk of getting a blood clot in the leg of the lungs.
Hmm.
But some people can get some breast tenderness, some get some nausea, some can get some moodiness. Those are probably the most common things that we see with birth control pills.
Sure. Okay. All right. I'm going to go to a different question, Howard, which is how long does one take the pill before we should change our plan? But I guess the more important question is what happens if they don't have pain relief?
Great question. So there's no absolute right or wrong answer because question is how long do we do medical therapy before we go to surgery?
Mm.
Something like do a diagnostic laparoscopy to look for endometriosis. And I think that comes down to individualizing patient care. A patient might want to try a different pill. For example, the interesting thing about pills is they have different doses of estrogen. So you can go up or down on the estrogen, depending on if
Yeah.
it's irregular bleeding, maybe you go up a little bit. If it's really nausea or something, you can go down. And then also on the progestin, there are all sorts of different progestins. There are like fifth generation progestins now. So you can give some that are very anti-androgenic, meaning will treat acne. And then there are others that have different side effects. So I often mix up what birth control pill I prescribe to them and say, we can try a different one as long as it really is different by either dose or the content. And of course, looking for other causes as well. And if they get to the point where they just say, I've tried NSAIDs, I've tried all these either progestins or combined oral contraceptive pills, I'm just done. I really want to know is endo. Then I think that's a reasonable thing to do.
Gotcha. Okay. I love it. So this is the question another listener had, which is just progressing on here. Is it true that it takes surgery to diagnose endometriosis? So give me your thoughts on that, Dr. Shaw.
Great question, because it's yes and no. The true diagnosis of endometriosis is excising a piece of what you think is endometriosis, having it examined under the microscope and seeing endometrial glands and stroma, meaning it looks like the lining of the uterus, but it's
Yeah.
outside of the lining. That is the diagnosis. Having said that, we don't require that of all patients. For example, if I do an exam and I feel nodularity on pelvic exam over what we call the uterosacral ligaments, that is going to be endometriosis 99% of the time.
For sure.
So you probably don't have to diagnose them that way. Or if on ultrasound or CT or MRI, you can diagnose endometriosis within an ovary called an endometrioma. That
Right.
has very high correlation with endometriosis. And you probably don't need to do surgery to make that diagnosis. But so there's a little bit of a distinction there, but technically we have typically said, yes, histology is the gold standard for endometriosis.
Okay, so I'm just going to ask the question. This wasn't from one of our listeners, but let's say you can confirm the diagnosis. Is it appropriate, especially in the case where you have an endometrioma or you have a nodularity on just right outside the uterus at the uterosacral ligament, is it most appropriate to proceed with surgery? What are your feelings on that?
So it might be. Let me give you some extreme examples. I have right now about 8 to 10 patients that were referred to me by a gastroenterologist or a group of gastroenterologists who were doing colonoscopies, did a biopsy, and found endometriosis. So they thought that they were
Wow.
biopsying a mass, and it was endo that had grown all the way
Wow.
from their peritoneum into their rectum and into the mucosa
Not
of the
very
rectum.
common. Wow.
So, and I am treating them with medications. I have not taken them to surgery. Now, sometimes we do get together with a colorectal surgeon and we resect that. We do a low anterior resection or other types of surgeries, but there's a lot of complications with that. If you can manage them conservatively, great.
Okay.
Very reasonable thing to do. Now, I don't know if we want to talk about excision versus ablation of
Yeah,
endometriosis
let's
yet.
talk. I think it's a great conversation
Okay.
to have. And maybe can you maybe define what that means?
Yes.
Excision versus, yeah, yeah,
There has been this debate about endometriosis as to if you're doing laparoscopy, should you burn it or cauterize it or fulgurate it? It's not
yeah.
really cautery. Cautery is when you brand an animal with, we don't do that. We use electrosurgery and we fulgurate or sometimes vaporize lesions.
Okay,
Excision is when you actually cut the tissue out. And,
okay.
cutting the tissue out sounds really good in that it's out of the body and you can make a diagnosis. And truthfully, you ideally should make a diagnosis because sometimes you get fooled and it looks like endo and it's not. Here's the tricky part. So if you look at some of these documentaries online, you will see there are at least 7 documentaries about endometriosis, and they're good because
Interesting.
they
Okay.
raise awareness about this disease that is really problematic.
Do you know who's funding those
I
documentaries?
don't I don't know who's funding them, but I
Interesting.
think some of
Okay.
them are independent, but they're
Yeah.
out there like
Okay.
Endo What
Okay.
and Below the Belt. Those are
Okay.
a couple.
Okay.
But and I think they do a good job of raising awareness. One of the
Okay.
problems is they really stress that you have got to go see someone who excises endometriosis.
Mhm.
And some of these doctors will charge five to $10,000 cash before they will do anything.
I've
You know,
a patient do 30,000.
oh wow, that's high.
Yeah.
That's
Yeah.
something. The problem is there are no data to suggest that excision is better than ablation. And if you don't believe me, go look at the Cochrane Review, which a bunch of really smart statisticians and people
Yeah.
who know how to grade literature get together and look. There are 2 randomized trials on ablation versus excision. 2 in the entire world literature.
It's
The
not many.
Cochrane.
Just for
No.
just for everybody who knows, that's not many
Yeah.
randomized controlled trials.
Yeah. Compared to myofascial pain, there's more data on that than endo.
Yeah.
But the conclusion that the Cochrane review came to was there is no evidence to suggest that excision is better than ablation. And in fact, based on the evidence, it may actually be the opposite. So I think we have to be careful about what we recommend and kind of gets publicized to a vulnerable group of patients because people who have pelvic pain would do just about anything. So that's one piece, and I'm happy to send that literature to anybody who wants it. It
Perfect.
is there. I remember once at a meeting, someone said, "In God we trust, all others must bring data." So, yeah, well, I've got the data on this. Okay. You don't just have to trust me.
That's good. Okay, this may not be for your listener, but let's say this is for the people who are providers for this. And let me ask the question to you, Howard, with your experience. Do you find that it is safer for you to do excision versus ablation? What's your
Yeah.
experience with that?
We tend to do excision here. There are some areas that I wouldn't excise. If you're right on a vessel, you don't want to get into something that's going to cause
Yeah.
tremendous problems. I have had a case where it completely encased the ureter. Ureter was obstructed because of endometriosis. I think
Sure.
in that case, you've got to restore function. And so we did bring in a urologist and specifically resected that with them because they had to
Yeah.
reimplant the ureter. We actually knew that going in. And so we had them available. It shouldn't be the case that there are just multiple injuries to rectums and ureters with this. Then you wonder, are you achieving the goal? And another point to think about, and don't let me get ahead of things, but
Oh, you're
remember,
doing great.
sometimes endometriosis isn't even the cause of the pain. So that's another
Yeah.
big issue that when we think about doing a workup, they may have endometriosis. Yes, absolutely. They have pain. Absolutely. Sometimes it's true, unrelated. For example, remember, there are a fair number of folks that you're doing a tubal sterilization. They have no pain whatsoever, but they have endo. You
Right.
find it. And
Right.
that has been
That's true.
diagnosed, that has been documented in the literature that somewhere between 5 and maybe even 30% of asymptomatic women have endometriosis. I would say most of the patients that I see don't just have cyclic painful periods. They've got pain every
Yeah.
day. And if you've
Yeah.
got pain every day of your life, the likelihood that you're going to get relief just with laparoscopic excision or ablation of endometriosis is about 1 in Avogadro's number, right? It's just not, it's not likely to happen
Which is
because it doesn't.
6.2 times 10 to the 23rd. I
Yeah,
just
yeah,
was trying to pull that out.
it's low. It's low. So that's the big thing is if my typical pain clinic day is I'm seeing patients who are 36 that have had anywhere from 3 to 10 surgeries.
Yeah.
And I interview them and I say, how bad are your periods? They say, they're bad, but I'm bad every day. I am
Yeah.
bad 30 days of the month. Or they've had everything removed. They've had one ovary removed, then the other one, then the uterus, everything's out and they're still having pain.
Right.
And it just doesn't really fit with endometriosis. So
And I actually, you're the expert on this, but I have found that the history typically happens, like the question the mother asked about her teenage daughter, for years with pain and maybe never resolved. And then you go from years of cyclic pain to longer pain throughout the month. And you start entering into a different kind of pain. I don't know if we call it a cycle or a pain syndrome. And that actually has to be addressed.
Yeah. So that used to be called central sensitization. Now it's called nociplastic pain, where there's no lesion, there's no inflammation, there's nothing there that you would see on imaging or even at surgery. But this patient is absolutely having a terrible time with extreme pain. And you're right, Daren. Sometimes it starts out as endometriosis. It's not taken care of or it's not addressed, and then it grows. And the central nervous system is seeing this continued input that it is just overwhelming the system. And then you've got this nociplastic pain, or yes, your central nervous system has become sensitized. At that point, you've really got to treat with other things. And then you've really got to think about what is your diagnosis and what are you going to do? But surgery is probably not going to be the thing. Let me just add one thing though. The crazy thing about nociplastic pain is that if you do surgery on someone for that, most are going to get better for about 3 months. So when you do surgery, you essentially, you reset the nerves. You basically cut their head off for an hour while you've given them general anesthesia. Maybe you've distended the abdomen.
And you've maybe relaxed the muscles.
All those things. So almost there are a number of studies that say, no matter if you go in and you do absolutely nothing, for 3 months, most of those patients do great. And then it slowly starts coming back. And part of it is I had this endo surgery. I did great for a while. I want another one. And you can't blame them, but it is probably not the surgery itself, the endo surgery. It may be the anesthesia. Things to think about with that.
Interesting. Yeah. It comes to the question that one of our listeners asked, how quickly can endometriosis return after an ablation by exploratory laparoscopy? And I think we've addressed it a little bit. I think that the thing that the listeners need to be aware of is that it may not be endometriosis related pain, even though you've had this significant endometriosis surgery.
Absolutely right. Endometriosis can really come back almost any time because unless you're suppressing after surgery, we don't exactly know the origin of endometriosis. There are 4 or 5 theories out there about this, but it might be there at the month afterwards. But is it really the cause of pain? And that's one reason that if you do surgery, I usually recommend suppressing afterwards, meaning if you can put them on progestin or a combined oral contraceptive pill, just to reduce that chance.
And just to stop their periods, which is one of the theories that you get this flow of the endometrium in through the fallopian tubes into the pelvis.
That retrograde menstruation is still there. There are a lot of folks that don't believe in that and others really do. And we don't know for sure.
Yeah, that's right. Good. I think that addresses one question that somebody had, which is ways to prevent it from growing. So thank you for asking. Let's see. So this is another question the listener has, and we may want to move on from endometriosis after this, which is, I haven't had issues with endometriosis since I had my babies, and I have to take the pill. Does it go away is the question.
Yeah, it may not go away, but it can be dormant or suppressed. There's probably a life cycle to endometriosis where it's probably worse in one's 20s and maybe 30s, but then sometimes the lesions burn out over time. And we don't see it as much in one's 40s. And now we can also talk about postmenopausal endometriosis and endometriosis after
Okay.
hysterectomy, which can still happen, but it's a lot less common. I think it's good if one doesn't have risk factors and if one doesn't have a hard time taking hormonal suppression. I think it's a good way to go.
Great. Which is one of the questions another listener asked, which is, can endometriosis still grow after hysterectomy? And what are the factors that would be maybe in play there if that were to happen?
Yeah, there are a few articles on this, and it's really, in fact, there was one just a couple of years ago in 23, I think it was in the American Journal of OBGYN, that noted if you leave the ovaries in, there is a higher chance that endometriosis comes back. Now, we are fans of the ovary. We like to keep them in because it gives patients estrogen, and it also allows patients to get some testosterone. Which gets converted back into estrogen. So there's a lot of good reasons, if there's not a family history of ovarian cancer, to keep the ovaries in. Even in one's 60s, we will leave them in, even though they've gone through menopause, is one school of thought. But if you leave them in, yes, they do have a higher chance of developing endometriosis. Here's the interesting thing, though. If you look at this, one of the papers that was done very well a couple of years ago, they found that even though endometriosis is more likely after hysterectomy, if you leave the ovaries in, it made no difference in terms of clinical outcomes. So opioid use, doctor's visits, and other medications given for pelvic pain was no different in the two groups. So it may not be actually the endometriosis that is the cause of the pain. It's all these other things that we were talking about.
Gotcha. So take home is keep the ovaries in.
I think so. I'll throw one caveat. If there's an endometrioma, I would get it out. And the reason for that is there is a slightly higher incidence of ovarian cancer with endometriosis, with endometriomas, particularly clear cell and endometrioid ovarian cancer is a little higher risk for those. So yeah, if they got an endometrioma, I just as soon get them out if they're close to 50.
Perfect. Any other things you'd like to talk about? This is the time. You have the time. You want patients potentially to know about this topic, pelvic pain, endometriosis, etc. Maybe any final comments on it?
I think the key thing is to know what the main symptom is. So is it cyclic pelvic pain? Because if it's cyclic, I have a little algorithm that I have made, which is all starts with, is the pain cyclic or not? And if it's cyclic, then I'm going the endometriosis. There are a few of the things like cervical stenosis, adenomyosis, which is a cousin of endometriosis. But if not, then I'm going down a whole nother path. And we can talk about that too, if there's time. But I find that most of the folks that I see are actually down this other path that maybe got misdiagnosed as endometriosis because it happened to be there, but it didn't fit with their symptoms in terms of they're having pain every day. So
gotcha.
That I would start with that. Well, that basic question is the first one.
I love that
to think about.
Maybe let's just touch on a few of those topics because I think it's important. I find that most patients will come into the office and will want you to take them to surgery to address their endometriosis, and they have pain every day. So it's the non-cyclic kind of pain. So what are you seeing more in your office that really patients should be aware of or listeners should be aware of so that they know that they're coming in to say, hey, I need to have maybe a full evaluation of what's going on with my daily pain?
You bet. Super important. So what I like to do is first we do the history, we do a physical exam, and we do a pretty in-depth history. I have them fill out a form, which is like 9 pages. And then we do an exam, which is pretty extensive. And I hope that patients will keep an open mind. And sometimes it's really hard because they've been told they've got endo or adhesions, and it's hard to let go of that. So a lot of what I end up doing is just educating. And that's why I appreciate you doing this, Daren, because this is so critical, is to educate. But then I think, is this pain, if it's not cyclic and it's not ovarian or endometriosis, is it musculoskeletal? So we do a full musculoskeletal because
Okay.
The female pelvis, you're on two legs, right? And then on those
Yeah.
legs is a pelvis that has three bones in it. And if those are off in any way, you got all the pelvic floor stuff, right? Pelvic
Right.
floor spasm, then all the abdominal wall stuff from motor vehicle accidents, surgeries, all of that for myofascial pains that you have done a lot of work with. So musculoskeletal are the leg lengths equal? Is the sacroiliac joints, are they in alignment? Do they have trigger points in their abdominal wall or their pelvic floor? So that's just one aspect.
And how have you responded to your painful periods for the past decade? Do you lay in bed and curl up in the fetal position and just tense up those muscles in response to the pain? I think that's where you start seeing somebody who goes from endometriosis to that musculoskeletal pain. So,
Yeah, no, great
okay.
point. Yeah. Sometimes the only defense mechanism you have for pain is to clench your pelvis. That's all you got. It's like,
Yeah.
I'm just trying to hang on with everything I have. It'd be
Yeah.
really a problem. So thanks for bringing that up.
That's good. Yeah. Okay. And then what are the other systems that we should be worried about when we come
Yeah.
in?
So I always think about gastrointestinal. Is it irritable bowel syndrome? Is it inflammatory bowel syndrome? There are so many things. We have them fill out what's called a Rome-4 questionnaire. Is it bladder pain syndrome or painful bladder syndrome or the old interstitial cystitis? We have them fill out a PUF questionnaire on that, which kind of helps us know what's the score, what's the risk for that, because those could be very similar. And then the nervous system. Do they have more neuropathic features or nociplastic features? Is it shooting pain? Is it burning pain? These are all things that have to do with neurogenic type pain. So you really want to think about these. And then, of course, there's organ specific on exam. Is it just the uterus? This is super tender. Is it the cervix or the ovaries? So these are more organ specific things that if the uterus is tender, but everything else is tender, like the pelvic floor, the adnex, everything, that's what we call a multifocal exam. And doing a hysterectomy on someone who, yes, the uterus hurts, but everything else does too, is probably not going to work. And then, I didn't mention vascular.
Oh, yeah.
Vascular.
Yeah.
We've heard about this pelvic congestion syndrome, which certainly has been a black box for years. The interventional radiologist really got looking into that, and they've breathed life back into it. And I think there are those cases that really have really big pelvic varicosities that sometimes get better with surgery or meds. So vascular, nerve, musculoskeletal, organ specific, all these things are worth looking at.
Okay, so I'm going to just follow up with this question. This is for listeners who are providers. And I think the question that you had on your bio, which was, how do you prevent burnout in somebody dealing with chronic pelvic pain? So I'm just going to ask that question. What has been your solution for that?
Not that I have all the answers on this, but I know what has worked. I've done it for 30 years now, and I do it on Wednesdays. I mean, they're in my other clinics as well, but Wednesday is my dedicated pelvic pain clinic where I have a resident with me. And I love teaching the residents. I love getting a patient in that just says, I have no hope in life. I feel like life is almost not worth living. And then I hear their story and I'm in awe. It's, oh my gosh, this is terrible. And then I find a thing or two on exam or history and it's, we can fix this or we can help this. And just seeing them have a glimmer of hope and then get better is wonderful. And so I think the key thing is if you go into pelvic pain thinking that everything is endometriosis, and then you are giving them all these endo meds and surgeries for endo and they're not getting better, oh, that'd be frustrating. I don't think I could handle that. But if you have a bag of tools that can say, I can fix vascular stuff, musculoskeletal stuff, neuropathic stuff. We haven't even talked about the meds for neuropathic, but there are a whole bunch of medications that can be used. So it's the hope that I see in a patient that comes in completely despondent that then has change in their affect that really makes me excited about it. It can be hard. It would be wrong for me to say that I see everyone get fixed, but I think almost everyone can get improved and most can get significantly better.
Yeah, you're absolutely right. They're tough patients because they have a tough problem. which is chronic pelvic pain. And nobody wants to deal with pain every day. And so that's awesome. Thank you so much for addressing that. We're just going to switch gears just a little bit and talk about pain with intercourse, which the term is used, dyspareunia. I'm just going to give you a scenario and we'll just walk through what you typically do and the things that you typically see. We have a 24-year-old with several years of pain every time I attempt to have sex. Is there anything that I can do?
You bet. So this is a patient I see every week, maybe multiple a week. And I start with a history, of course. That's always the start. Did they have pain with tampon insertion? Did this occur just first time with intercourse, or were they fine? And then did it happen after pregnancy?
Yeah.
Because those are the key things. Because is it vulvar vestibulitis, where the glands right at the opening to the vagina start become very sensitive? And those are the clues for that. Or sometimes it's, as you mentioned, the pelvic floor that is super tender. So I start with the questions, and I do an exam, and I just check right at there's a area right at the vestibule, which is about a centimeter in to the vagina, which is right around the hymenal ring. It's important that you look on the distal aspect, not the proximal, and that's meaning closer to my side, distal from an anatomic standpoint, because the glands are only on the minor vestibular glands and up to Skene's glands. But if you touch that and everything else is not painful, and that is painful, then that's almost always vulvar vestibulitis. I've seen hundreds of these patients that have really tough stories, but we get a 90% cure with that. So I do.
It's amazing.
I check the skin, I check the muscle, then I check cervix, uterus. Is it the uterus? Is it deep pain or is it superficial pain? And I split them into those categories, but there's some overlap. I just say we could spend an hour on this, and I'm trying to do it fast.
Yeah. Let's talk a little bit about some of the treatments. What do you do for this 24-year-old?
Yeah. So let's say this person is diagnosed as having vulvar vestibulitis.
Okay.
First of all,
probably the most common in this scenario, right?
Super common. And it is, first of all, it's nothing they've done wrong. If it happened after a delivery, it's probably what we call secondary vestibulitis, where it's the immune system, which has gone from having to accept that a baby, which is a little bit of a graft,
stress,
if you will, that to all the, you don't want to reject a baby. And so sometimes you have some issues going on that are immune mediated. If they have that, I usually try some topical therapies, and there are a few of these published. I use amcinolone ointment. I don't use creams, but the ointment and clobetasol can be used. And I usually have them use a very thin film twice a day for 4 weeks, 4 to 6, and see if they get anything. Sometimes I'll use estrogen. You think, why would you do that? They're making a lot of estrogen. If they've been on a progestin, that's helpful. And I've just had some patients that did better with that. You can use lidocaine. I find lidocaine to be pretty irritating, but those are some things that we do.
Sure.
If they don't respond to lubricants, dilators, things like that, topical things, then a lot of times I will offer them a vestibulectomy, where we just excise about a 1 centimeter area that's just a little horseshoe around the vestibule. And we get about a 90% cure rate with that, it's an amazing thing to see folks get better with that.
Yeah. So amazing. That's awesome. We covered that really quickly. So I don't want to belabor that point, but some amazing things you're doing on that. And you taught me some amazing skills that I carried through the rest of my practice. Those are life-changing moments for patients, for sure.
You're a great doc, Daren, and it was a pleasure to get to work with you for a while.
Thank you. All right. So this is maybe on a little lighter note, and I don't know if I sent this to you and if you've had any time to think about it, but I'm just going to ask you 5 things that you would never do as a doctor.
I should have thought more about this, but first of all, I would never not listen to a patient. That's probably the main thing. And the other thing I wouldn't do is say, unless I absolutely knew what the diagnosis would, I would not say this is absolutely your diagnosis. Because remember, we live in grays. So the worst thing you could do is be wrong and then have a patient lose faith in you. So those are a couple of things I wouldn't do.
Good.
I would not listen to country Western music.
For sure.
That's just me. Where you said lighthearted here. And those are 3 things. How's that?
I'm just going to add one from what you had said, that I would never say that this is in your head. And we hear that all the time in somebody who has chronic pain, right? Never say those words.
Yeah, for sure. That's a great point. And even though we try not to say it, sometimes patients hear that. And so, yeah, thanks for bringing that up.
Okay, I'm going to ask one other question. I used to always love it when patients would say to me, how come you chose to be an OBGYN? And it was more, are you a pervert? Is there a reason you went into OBGYN?
Yeah.
And you can give me some insights. Why did you choose OB and why did you choose chronic pain? I think
I have to say it's really my father, and who passed on about 5 years ago. He was an OBGYN, and I just always looked up to him so much. And I don't know, there was just a familiar, I also have 6 sisters, so I'm used to being around women, but I thought about general surgery and OBGYN. In fact, I did a general surgery sub-internship and enjoyed it, but it was a lot of gallbladders. And OBGYN is just so much of everything. And I've just loved the variety of it. My father was the one that actually started this pain clinic. So everything that I'm doing now is totally built on what he did. And he started with some of the great doctors at the pain management clinic here that are mostly anesthesiologists.
Interesting.
I owe everything to him, but it's been a great time.
Howard C. Sharp, our hats off to you.
Yes, thank you.
It's so awesome to be with you, Howard.
Well, I say likewise, my friend. You're a good man.
This has been an amazing time for me. So I just want to say thank you to all those who've made this possible. Natalie Watts, who is the president and CEO of Not Your Doc Anymore, LLC, our social managers, Taylor Seberg, Emily Brown, and Sarah Marion, and our production manager, Joshua Watts. I just wanted to clarify this, that the medical advice or the procedures that we've discussed do not substitute for your own professional medical consultation. In addition, listeners or viewers need to be aware that the information we've provided, there are limitations generally. And so seek medical care. Use this as a way to understand the questions that you should be asking to help you become your best advocate as you go to see your physician. So thank you so much, Dr. Sharp.
Thank you. It's been a pleasure.